wants to start with eczema. This is a really, some of this is kind of detailed that I'll skip over because you guys have the handout. But okay, so we'll start with contact dermatitis. So this little boy, what do you guys think? What do you think happened to you? Any ideas? Ooh, that's a good one. Sunscreen. Ooh, that's a good one too. So this is a type of contact dermatitis, and it was poison ivy. So contact dermatitis is a chronic or acute inflammation of the dermis and epidermis, sorry, as a result of either direct irritation to the skin, which is irritant contact, or delayed hypersensitivity, which is contact allergen. So there's a difference, and I see this a lot in practice. You know, people will come in and they're like, well, why are my eyelids crusty? And it's like, well, you haven't really been around anything, but it might have been that you were around an irritant. So people always want to come around and say, well, I'm allergic to this. And there's a difference between being irritated by something or being allergic to something. So, you know, that's the main thing I see is irritant contact dermatitis. So there's a couple different kinds. And like I said, about 80% are irritant contact dermatitis. Skin reactivity is highest in infants and tends to decrease with age. Allergic contact dermatitis is less common in infants and children than in adults because children have less time to develop sensitivity. So a lot of times, if you think about like diaper dermatitis, it's not that they're allergic to their pee and poop, and it's not that they're allergic to their diaper. And that doesn't even mean that they need to have cloth diapers like some people think. It's typically just an irritation of the diaper area. Prevalence increases with age and is increasing in children most likely due to frequent exposure to allergies at a younger age. Maybe it's just, we're just seeing more irritant dermatitis. So risk factors for contact dermatitis include frequent hand washing or water immersion. So a lot of people that like, you know, wash dishes a lot, or, you know, healthcare workers that have their hands, you know, they're washing their hands a lot. If you have atopic dermatitis because you've got a bare ear dysfunction, that's a risk factor. Genetics, environment, and increased exposure to allergens. So anybody that's like touching chemicals a lot. I had a guy that came in and he was a mason, and he had this awful dermatitis, and it looked more contact because it was a lot more vesicular, it was oozing, and we had put him on so many steroids. Finally, we did patch testing and come to find out he was allergic to a preservative in his concrete that he was using. And I was like, well, it's your way of life, so we had to treat him. We did immunosuppress him, essentially. So, pathophysiology, I'll keep this short. The irritant contact dermatitis doesn't involve the immune system. It can happen with the very first exposure to an irritant. There's a disruption to the epidermal barrier, damage to cell membranes, and a cytotoxic effects on the skin cells. Chronic exposure can stimulate cell proliferation. With allergic contact dermatitis, typically you have it after you've been exposed to it initially. So that's kind of the difference, you know, more immune system involved with allergic dermatitis. Again, etiology with irritant contact, hand washing, soap, saliva, urine and feces with diaper dermatitis. Allergic contact, you know, you think about different things that people that are high contact allergies, like nickel. So like people's buttons in their jeans, a lot of times people are allergic to that, or earrings that have nickel, sorry. Hair products. I'm going fast, aren't I? Cosmetics. I see a lot of women that come in and they've maybe used an eyeshadow that they've used forever, and they keep putting it on after a while, and they're like, hey, maybe it's my eyeshadow. No, maybe it is. You know, maybe we should try something different. Rubber's a big one. Fragrances. I cannot talk today. Balsam of Peru is one of the most common fragrances that people are allergic to. Dyes, formaldehydes. Topical antibiotics. I cannot express to you how much I hate Neosporin for this reason alone. So don't ever let anybody use Neosporin, containing products. And plants like poison ivy. So the history, they're typically always pruritic or itchy. And they sometimes can point out an exposure to a chemical. Most times people will say, I think it's poison ivy. I've had this before. They might say, oh yeah, I work in a factory, or I work around chemicals or something like that. But sometimes they can't even associate a specific allergen. Irritant contact develops immediately whereas allergic contact takes about 48 to 72 hours. Location of skin changes may provide clues because reactions are typically localized to the areas that come into contact. So with poison ivy, it's typically their legs because they brushed up against the plant. You know, nickel from the button, it'll be around their belly button, that sort of thing. History is of utmost importance. I mean, ask them anything and everything. I even had a patient come in and she just had redness around her face, neck, and décolleté. Nothing back here, nothing on her back, her arms were clear. We started talking and come to find out she's highly allergic to poison ivy, although she hadn't been out around it. Her neighbor had been burning it, and so it was an airborne allergic contact. It was awful. So, I mean, just weird stuff like that. That's why history is so important. So I always ask them about any changes in any products they've used or travel anywhere or being outdoors, that sort of thing. Document when the rash started, where did it start, how did it spread, shape, size, being pruritic versus non-pruritic. A lot of times if you're suspecting something irritant or contact and they're not itchy, think about other things. Think about an infection. Think about a neoplasm. I mean, it can be all kinds of stuff. Because typically with eczema or contact dermatitis, it's always itchy. Ask them about having any pain or warmth, swelling, that sort of thing. I also ask what they've used to treat the rash. If they've used a steroid and it gets worse, sometimes you think about, oh, maybe it's a fungus, because the steroid's just sugar and that feeds the fungus. But if they've used, you know, a steroid and it hasn't gotten any better, maybe it's gotten a little bit better, you can kind of know that it's inflammatory that way. Has your child ever had this before? That's if you're talking to a parent. The physical exam, the acute cases, they can have some mild skin dryness, some redness, but then it can also be patches, papules, vesicles, oozing. Chronic cases, it's typically lichenified. I'll kind of show you what an example of lichenification looks like. It's basically because you scratch so much that the epidermis thickens, and it's almost like a barrier that your skin has created to prevent any more trauma. Hyperkeratosis is another kind of thickening of the skin. Cracking and scaling, those are secondary effects from scratching. Chronic lip lickers can also have a perioral rash. If you see a little kid come in, the mom's like, well, I've been using my oil, it's not helping. It's like, okay, well, it's because they're licking their lips. So that's very common. Often unusual pattern of distribution that correlates with pattern of exposure. So linear patterns are typically when you're brushing up against poison ivy, so you can kind of see where the line of the plant went. If it's round, it can be from like nickel in a button. So sometimes you can tell exactly where it touched the skin just based on the shape. Auto-eczematization or id reactions occur as a generalized dermatitis, and it's typically away from the original site of dermatitis. So sometimes if people come in and they're just head to toe eczema, you can kind of look around and see maybe where they had the initial contact. And typically they're just a highly allergic person. They've got a history of eczema, asthma, allergies, postnasal drip, all of the above. Diagnostic tests and procedures, typically I don't do any labs unless I think that maybe they have eosinophilia, which is very rare. So sometimes you can get like a CBC and see a high IgE level. Formal epicutaneous patch testing. It distinguishes irritant from allergic contact dermatitis. So it will tell them what they're allergic to. Now, the problem with this is it's expensive. I typically refer out for it, and sometimes even if you know what you're allergic to, it's in everything, so you cannot avoid it. It's just kind of providing the patient with answers, so if they can try to avoid it, they will. So the patch test involves controlled exposure of multiple allergens to the skin. If you go to like Oklahoma Allergy and Asthma, they'll test for like 96 different ones on your back. They did this to my daughter, and she wasn't allergic to anything, but you know, you can tell specifically what they're allergic to. So positive reactions manifest with the development of erythema, edema, and vesicles at the site of exposure, usually within 48 to 96 hours. So if they get a reaction quickly, it's typically an irritant, but if it's, you know, that 48 to 96 hours, it's typically an allergy. Patch testing for poison ivy or oak is not recommended because reactions can be severe. I don't know why that is, but they typically don't test for that. In your differential diagnosis, and I think that this is important, especially if you want to do a biopsy. When you do a biopsy and you suspect contact dermatitis, you kind of want to give the pathologist something else to go off of. So I think it's good to provide a good differential list. This includes urticaria, atopic dermatitis or eczema, drug eruption, nummular eczema, bullous pemphigoid, and viruses. So treatment is typically involving identifying the allergen or offending agent and decreasing exposure or just getting them away from the offender. Emollients restore epidermal barrier function. Petrolatum-based products are preferred to emollients containing lanolin because contact sensitization can occur with that. And frequent application. Prompt bathing with soap and water immediately after exposure to poison ivy, oak, or sumac may help reduce exposure. Maybe. If you're really allergic to it, probably won't do anything. Chemical inactivators of urushiol, which is the poison ivy chemical. It may decrease the dermatitis, but oil-removing compounds and soap also decrease dermatitis when used promptly. So you don't have to spend the money on that kind of stuff. When they have acute allergic dermatitis, application of cool compresses and things with drying properties like calamine is good. Anything with colloidal oatmeal, like I think Aveeno has a really great product for the bath. Topical corticosteroids can help with pruritus and inflammation with acute and chronic dermatitis, and it may resolve in 1 to 2 weeks. Typically, like poison ivy, if they've come to you, the dermatology office, that's a bad reaction, or they didn't use the correct stuff. With irritant contact dermatitis, topical corticosteroids are controversial. I use it all the time in irritant dermatitis, so I haven't seen it not help. If it doesn't, then you know it's more they're just continually being exposed to it. And you have to try to investigate it a little bit farther. Milder areas like the face, flexural areas, under the breast and the groin, that kind of stuff, you can use a class 3 to 5 topical steroid. It's a little bit less potent, and plus, anytime there's folds, it's going to increase potency because of the warmth. So you only want to use about a class 3 to 5. You'll learn all about the different types of topical steroids. We have a little thing that we carry around in our pocket that tell us the classes, and you kind of become used to the ones you like. For severe or chronic contact dermatitis with the lichenification, like we were talking about, medium to high potency, like class 2 to 4 for a short duration. I don't typically have to have anybody use it for more than 2 to 3 weeks. If they have eczema, that's sometimes a different story. As long as they're using it to affected lesions, not just normal skin, you're typically not going to get the side effects associated with topical steroids. Systemic antihistamines, that's like Benadryl, Zyrtec's another great one that lasts 12 hours, is less sedating, that sort of thing. It can help if they're itchy. If they're not that itchy, it's really not going to do very much. Severe cases involving large body surface area with facial, genital, or extremity edema, you can do a short course of systemic steroids. And that's just at your own discretion. You know, you can do just a Benadryl dose pack, which is a quick 6-day course of a really low dose of steroids. It helps, but sometimes you have to do what I call the poison ivy dosage of prednisone, and that's when you're starting at like 60 milligrams a day. I kind of reserve that for patients that are it's all over, or a suspected drug rash, or a Benadryl dose pack just didn't touch them. So I've done that before several times, and it helps. You can also do topical calcineurin inhibitors. That's, again, the Elidel, the Protopic. It does sting, especially if you've scratched the skin and irritated the skin. So sometimes what I'll have them do is like a little layer of Aquaphor or Vaseline first, and that kind of helps. Even putting the tube of medicine, bless you. Even putting the tube of medicine in the fridge helps because it's cooler when they put it on. But they're a lot less effective than mid-potency corticosteroids. Also, a long time ago when they released Elidel and Protopic, there was a FDA-issued warning about its link between topical application and lymphoma, and it's really ridiculous because when they did the study with Elidel and Protopic, they were feeding it at large amounts to rats, and some of them developed lymphoma. But we're not feeding it to people, and we're not, you know, giving it to them at the highest dose possible. We're giving them a very small dose, and they're putting it on their skin. And I think transepidermal absorption is very low, so it's not really going to get into their bloodstream. So I don't let them worry about that kind of thing. So this little boy, yes, has poison ivy dermatitis. And this almost looks like it was airborne more than just, going across his face and causing vesicles. This is another case of contact dermatitis. This could be lip lickers dermatitis just right there. It's a little bit crusty. Sometimes they can get secondarily infected as well with a little impetigo, and you have to treat both the dermatitis and the impetigo. This is a chronic dermatitis with some vesicles. And it's harder to treat on the extremities, especially the ankles and feet. You've got to use a pretty high dose topical steroids for several weeks, more than the recommended 2 to 3. This lady was probably using something around her eyes because it's kind of localized to that area. And this little guy, that's a pretty severe reaction, using eye drops that he was allergic to. So he's got a little impetigo too, so I'd probably give him some Pathophysiology as well. And sometimes that can help him heal up really, really nicely. And this is more, I don't even know, maybe irritant dermatitis from heat and sweat. Other examples, more vesicles, papules. That's more eczema related. The bottom right picture is more looking like a contact allergen because there's like a line of vesicles. So then we get into diaper dermatitis. The diagnosis is basically on history and physical alone. Physical exam reveals erythematous, scaly, eroded, painful lesions with sparing of the creases. That's very important. That's probably board's question type stuff. Spares or creases, you've got to think about the skin coming into contact with something. If the creases are involved, then you think about candida. So I remember that being a question on test and board. So for what it's worth, and they'll have satellite pustules again with candida. No labs. You can do a KOH if you suspect candida, or sometimes just a swab. Sometimes if it's really bad, macerated, oozing, I'll do a bacterial and a candidal culture. The main thing is, and this is hard because I was a mother with a baby at one point in time, and I tried this too, and I would get so mad at moms trying to keep your baby dry. That's almost impossible, but that's a big deal, and trying to decrease their exposure to the wetness. So it's a lot of frequent diaper changes and very diligent application of a barrier cream. This can be A&D, this can be Desitin, it can be Aquaphor, although I like Desitin a little bit better. And I tell them to do it with every single diaper change. And what I would do with my baby is I'd carry around a washcloth, and when I'd wipe her bottom, as long as there wasn't any poop involved, when I'd wipe her bottom, I'd just use a wet washcloth. I wouldn't use any wipes. You can use the unscented ones, but sometimes just even the chemicals from an unscented one can irritate their skin. And I would spread on that zinc like icing. I mean, just smack it on them. And then have them, let them run around without a diaper as much as they can to keep it dry. If you suspect candida, you can do the topical nystatin. Topical steroids are okay, a very mild potency one, like the class 3 to 5, just because it's their hiney and their genitals. Topical antibiotic like Bepirisin's nice if you suspect a little staph involvement. They're typically a little bit more oozy. They might be bright beefy red. And so that's really diaper dermatitis. So the main thing about diaper dermatitis is it spares the creases. Now when we talk about atopic dermatitis, otherwise known as eczema, there's a lot on here, but you don't have to know all of it, but it's some good information. It's a chronic relapsing pruritic condition that affects characteristic sites, and we'll talk about those sites. Mostly in infancy or early childhood with an age-specific pattern of involvement. They typically have a family history of what we call atopy or atopy, depending on where you're from in the country or how you say it. That includes asthma, hay fever, rhinitis, postnasal drip, hives, anything like that is considered atopic factors. 45% of cases start in the first 6 months of life, with 95% onset prior to the age of 5. 70% of affected children will have a spontaneous remission before adolescence. That's not to say that they're not going to have an in the future, because typically if I have an adult come in and I see they have nunnular eczema, I say, did you have eczema as a kid? Yeah, I had eczema as a kid. So it's nunnular eczema. So most of the time it recurs. Asian patients are more affected than Caucasians. I will say that is true. Usually worse in the winter, but I've had a lot of people come in and it's always worse in the summer because they're sweating and they're hot, and it just makes it flare. So it's not always worse in the winter. Genetic predisposition is huge. They do think, they have found this gene called the filaggrin gene. It's on chromosome 1, that there's an association between that and eczema. The filaggrin gene is involved in the coding for a skin barrier protein. So if that protein's missing, they can't properly form a skin barrier, and so they can get eczema. The reason that's important is a lot of the new drugs that we're developing for treatment of eczema, including some of our biologics, have to do with that filaggrin gene. And itch, scratch, so they always say it's the itch that scratches, or the scratch that itches. What is it called? You remember what I'm talking about? So you generally scratch it and it
scratch. They'll get itchy and scratch before you see the rash, and then it just is like
going on and on. So you're trying to stop that. It can be from skin infections, emotional stress, irritating clothes and chemicals, extremes of temperature, food allergy sometimes in kids. So if you see a kid come in and he's always just got this horrible eczema all over, maybe consider sending them for food allergy testing. It's really easy to do. Exposure to tobacco smoke is a big one too. Family history, asthma, and allergic rhinitis. So a lot of these kids will come in and they have the allergic pleats around their eyes, or they're constantly having a runny nose. Sometimes they can get what's called hyper-IgE syndrome, or job syndrome, which is atopic dermatitis, elevated IgE levels, and recurrent pyodermis. Pyodermis meaning just skin infections. So the two main hypotheses are immunologic with unbalanced immune response and/or skin barrier dysfunction. So it can be one or both. There's an alteration of the stratum corneum, which is that top layer of skin that results in transepidermal water loss and a defect in barrier function. Interleukin 31, upregulation is thought to be a major factor in the itching, and that's also important again because they're developing medications just for itch based on the interleukins. Pathophysiology, this is again IL-4, 5, 13. They're doing biologics on this too. They're coming out with so many different biologics for atopic, which is great because all we've really had up to now is topical steroids. But if you look at the physiology, it typically, if it's acute, it shows spongiosis, which is a specific look in the epidermis, and it can lead to vesicle formation. History, presence of major symptoms, including relapsing of the condition, family history, typical distribution of morphology. Questions that you want to ask: age of onset, location, if they're itching again, prior treatment, bathing habits, whether they like to take really hot baths or if they're bathing every single day, family history, asthma, allergic rhinitis, and exposure to allergens. Physical exam, the acute flares reveal erythema and scaly maculopapular exudative patches. Exudative just means that they're kind of weepy. So you can tell that it's acute if it's like that. Chronic, they're going to have hyperpigmentation or hypopigmentation. And again, that lichenification. Find a picture of that. There's diaperdermatitis. Here's diaperdermatitis. That upper left is candida, though, because its creases are involved. And there's satellite pustules. I'll find lichenification in a second. So this is kind of important, age-specific patterns of skin involvement. As a baby, it's typically widespread, so you'll see it on their face, their scalp, their trunk, any extensor surfaces. When they're a kid, it's typically the flexural surfaces, so creases of the elbows, behind the knees, sometimes the armpits, and there'll be lichenification. Hands and face, adolescence to adulthood, it's the flexures again, sometimes just the neck and hands. Sometimes they only have it on the extremities. Severe atopic dermatitis can present as exfoliating erythroderma with diffuse scaling and erythema. I have not seen this. If I saw somebody like that, I'd tell them to go to the ER. So, there's some other associated findings on there you can read about. Again, we talked about the distribution of the lesions with infants, children, and adults. Morphology, Infants typically have erythema in papules, and it can develop oozing, crusting vesicles. Kids and adults have a lot of lichenification because they've been able to scratch. Babies can't scratch like adults can. Associated signs, they can have facial erythema, perioral pallor, because it's like everything else is red except right around their mouth. The Denny-Morgan lines are those little pleats in their eyes, and they can have a lot of the purple discoloration under here, like allergic shiners, that sort of thing. Ichthyosis is a type of incredibly dry skin, almost, it's supposed to mean fish scale, so if they've just been scratching and they're not hydrating, they're going to have this fish scale appearance on their skin. Keratosis pilaris is another thing that they can get on the back of their arms, and it's prominence of the hair follicles that get real thick and scaly. So they might have those other associated signs with their skin as well. There's a differential list. Sometimes you have to think about tinea again. There's not really any labs. Biopsy sometimes can help, although a lot of times I'll do a biopsy and it'll just come back dermatitis, which does not help me at all because it doesn't tell me what kind. But it can tell me if they have psoriasis instead of dermatitis, which can mimic. IgE levels can be elevated, but I typically don't check for that unless they're just always, if they're always broken out, we might check an IgE level to check for job syndrome. It's very rare that I've done that. Again, you can do bacterial cultures of the skin just to make sure they don't have a super infection. Typically, you can treat it with Keflex if they do. They do this scoring of atopic dermatitis. I've never done that for anybody because I just look at them and I treat them. I don't need them to score it. They can tell me how bad it is. A zinc smear can identify the presence of eczema herpeticum. So if they come in and they've got just this hideous-looking eczema, and they've got a lot of vesicles and stuff, and it's around their bottom or their back or even their face, they can have like a super infection with herpes too. And it's not good. So there's no cure. Parents must understand that it's a chronic disease with intermittent flares, and control is the aim of treatment. So you have to explain to these people, listen, this is just, you drew the unlucky card. You're going to probably have this the rest of your life as long as you're diligent in taking care of your skin, having exams. We can control it. But I always tell them to keep a diary anyway. Sometimes they can tell if they eat a certain food or if there's certain environments that they're in that it gets worse. It can only help them to know what to avoid. Good skin care is critical to maintenance and includes use of mild soaps, frequent use of emollients, and wet wraps. What I've learned, there is no specific lotion I tell them to use. If they say, well, is Aveeno good or Neutrogena or CeraVe? I don't care as long as it's not scented and you use it right after a bath when you're damp. That's all that matters. I don't really lobby for one brand over another. I like Aveeno just because I haven't seen anybody break out in it, but there's no specific brand that I like. Bleach baths are really great if they're getting, eczema over and over again, and it's that bright red oozy kind because they're getting super infections. So what I always tell them to do is do about a quarter cup of bleach in a tub full of water and let them sit in it for about 10 minutes, and they can do this once or twice a week, and a lot of times their eczema will clear up like that. Vitamin D supplementation has been shown to decrease the severity of atopic dermatitis. So milk, maybe. They might be allergic to it, so don't tell them to do milk. Just go outside, which will also help with eczema. Avoid things that can cause irritation, so like wool, any kind of like natural fiber clothing, so I always tell them to do synthetic clothing. Perfumes, that sort of thing. Lukewarm bathing, not hot. I mean, scalding hot baths can make this so much worse. Minimize the use of soap. I tell parents really the only place they need soap is their hands, feet, face, and privates. They don't have to put it all over, and don't let them use Bath and Body Works. Sun exposure can be helpful. It actually decreases the immune involvement in eczema. Humidify the house. Avoid lotions that contain alcohol. So a lot of times you look at the back of it says sterile alcohol. That's one of the ones that can cause a lot of dryness. Medications, frequent systemic lubrication with thick emollient creams. Eucerin, I think, has alcohol in it, so I don't typically recommend that. People will just use Vaseline, and that's fine. I don't care. I like creams over lotions because lotions do tend to have a little bit of alcohol in them and they can sting. Infants and children, you can use the hydrocortisone. Adults, higher potency topical steroids. Short course, higher potency corticosteroids for flares, and then go back on with the lower potency ones. Typically, you don't have to do that. Antihistamines just for itching. Hydroxyzine is one that we use all the time. It's also known as Atarax or Vistaril. They'll give you Vistaril in the ER if you come in and you're crazy because it'll really calm you down, but it's just hydroxyzine. So it'll make them sleepy. Diphenhydramine is just Benadryl. You can do that. If Benadryl doesn't work, I'll give them some hydroxyzine, and it tends to help a lot, especially in babies. If they're just miserable and they're itchy all the time, I do find that that helps them. The topical immunomodulators like Elladelin, Protopic are great for kids over 2 years. Plastic occlusion in combination with topical medications for node absorption. So, you know, if they've got a lot of extremity eczema and it's really lichenified and you're really having a hard time penetrating those scales, I always use an ointment-based steroid, and you can have them wrap it with saran wrap at night, and they clear up really quick because it really drives the medicine into their skin. Sometimes you can do systemic steroids for about 1 to 2 weeks if they're really bad, like a nice taper based on their weight. Topical doxepin. Doxepin's an old drug. We used to use it as an antidepressant at really high doses, but it's so sedating. But they find it really helps with itch and sleep. So if adults come in with really bad eczema, they're like, I'm clawing my skin at night, give them a little oral doxepin or topical doxepin, and it makes a huge difference. And I have had some people have to do low-dose methotrexate, but I'll do it in adults. I don't ever do it in kids. If I ever think a kid needs it, I'll send them to pediatric derm because I don't want to have to monitor that because it involves blood work and all kinds of stuff. Additional therapies, you guys can read about this. We've kind of gone over most of this kind of stuff. It's a lot of education, and you're going to see these kids and adults quite frequently. Kids I typically see every about 6 to 8 weeks until they're controlled, and then I can give them like 3 to 6 months. But as long as they know their triggers and they know what they can and can't use, they're gonna realize what they need to do. They've just come out with an injectable biologic medication for eczema, and it's working really great. It's a shot they give themselves, and I've put probably about 4 or 5 people on it that just have severe eczema, and it's in adults. They're working on getting indications for kids, but it's showing a lot of promise. So it's just kind of one of those chronic issues. I'll show you a couple more pictures. This little baby, a darker skinned baby, has these little areas of hypopigmentation, and that's what we call post-inflammatory hypopigmentation. So, you know, depending on your skin color, you can get post-inflammatory hyper or hypopigmentation. So in somebody like me, I've had a rash, I'm lighter skinned, so the melanin in my skin gets kind of stunned when it's inflamed, and so once my initial rash is gone, I'm still going to have a lot of that hyperpigmentation until my melanin just kind of resets itself. So a lot of times they'll come in and go, well, she's still got a rash, and they really just have discoloration, so you don't want to use steroids on this because it can actually make it worse. So you just moisturize and tell them to wait. It's a scaly baby. Those are the popliteal fossa involved in a child with eczema. Ankles are a common area. You'll see babies come in that have eczema, and they're going like this the whole time. It's so cute, but you feel so sorry for them. And they'll just get this lichenification type scale around their ankles from just scratching like crazy. Again, the antecubital fossa. It's another area in kids. Lichenification. This is a baby with pretty bad dermatitis. You know, so if I ever had a baby with that widespread of a rash, I might do a CBC on them just to see how their eosinophils are looking. There's pretty bad baby eczema. You'll see babies a lot with it on their cheeks. Pretty bad one too. So you see that he's got kind of some pallor underneath his lips and kind of around his nose that spares those areas. And this is more what we call lichenitis, and it's a type of eczema that comes up with these little bumps on your skin, and it's not really red, and it's not really itchy. It's just kind of almost like a lichenification. There's another popliteal fossa. That's a lot of lichenification. And there's another little sweet baby. So that's, I mean, it has a lot of different presentations, but after you've seen it so many times, you can tell that it's eczema or not. And it's, a lot of it's history too, so. Let's go on to psoriasis. Does anybody have any questions? I said that really fast.